So my name's Justine Fitzpatrick and I'm the Assistant Director at the London Health Observatory. The London Health Observatory is one of 9 public health observatories in England. So this is what I'm going to talk about today. First of all, I'll just briefly describe what a public health observatory actually is, and talk about the role and functions of public health observatories in the UK. Then I'll talk about the London Health Observatory where I work, and then I'll provide an overview of the Health Inequalities Intervention Tool, which I think is what you're most interested in today. So this is essentially what public health observatories do. At the moment, public health observatories are most common in Europe, particularly in the UK, France, Belgium, Italy and Switzerland, but there is some interest in setting up public health observatories in Canada. So basically what we do is we provide evidence and information on the health of the population, the determinants of health and health inequalities, largely for public health practitioners in England, but also for policymakers and community representatives, with the hope that they will use that information to prevent disease, promote health and prolong life. So this slide demonstrates the sorts of evidence and information that public health observatories provide. And it's presented along a continuum. So on the left-hand side are the things that we do that are most responsive to our customers, if you like. So we operate an inquiry service, and we have a website where we signpost information for people. And on the right-hand side is our most proactive activities. So one of the most proactive things we do is advocate for better public health information and widening access to data. And then in the middle, you've got the whole range of the other things that we do. So we do in-depth analysis and interpretation of health data. We develop tools and methods for people to use, and that's what I'm going to talk a bit about today. We do a bit of public health performance monitoring, and we also operate networks, so we provide opportunities for people working in public health to get together and share experiences. You'll notice that this slide doesn't really mention research, and I wouldn't put research as something that we necessarily do. We don't do primary research. We use other people's research and we signpost research, but I wouldn't call what we do research. So this is the history of the English Public Health Observatories. We were established in 2000 following a government white paper. And we were established using national money from the Department of Health. And there's a public health observatory in every region of England, of which there are 9 at the moment. And we are required to work in collaboration. All the public health observatories are required to work together as the Association of Public Health Observatories. And a couple of years after they were established in England, they were set up in Scotland, Wales and Ireland. And these observatories have now also joined our association, so we work with those as well. And there is an AFO executive board which contains representatives from all the public health observatories in the UK, and they help to steer the work of PHOs and promote collaborative working. So this is just a map to show the location of all the public health observatories in England and in the rest of the UK. And when we were set up in 2000, the government set out a number of core functions for us, which are listed on this slide. And these are our core functions. These are the things that we are required to do, but we also do lots of other things as well. So the key thing on this slide is that we are required to work in partnership with researchers, regional and local health policy makers and practitioners. So we don't work on our own. Nearly everything that we do is done in partnership with another organisation. And the main things that we do, or our core functions are, we monitor trends in health and the determinants of health. We highlight future health problems. We assess the health impact of policies. We draw together information from different sources. We provide standard sets of community health information, and these are called health profiles. We do those together as AFO. And we provide a standard set of information for each local government area. And we also have a role in capacity building. So we run training courses for people working in public health on public health analysis, largely. And there are various advantages of working together as the Association of Public Health Observatories. So together, the observatories have quite a large concentration of analytical expertise. There are about 150 public health intelligence professionals in the public health observatories in England. There's about between 15 and 20 people working in each public health observatory, so we are quite small. We do have a wide range of partners, which helps to ensure the relevance of our outputs. As I said, we don't sit on our own and do work on our own. We're working with people who want to use the information. So that helps to keep us up to date. The network provides a role in quality assurance. So if we're doing a piece of work, for example, the Health Inequalities tool that I'm going to talk about later, we involve other PHOs in quality assuring that, so they will check our outputs and comment and help to improve the work that we do. And we are regional organisations, but we do sometimes work on national outputs. So if one PHO might develop something on a regional level, and then the others might decide actually that's quite good for their PHO as well, so we can copy and expand work that other people have done. And we've developed lead areas, so each PHO has a number of lead areas that they will work on behalf of all the other PHOs. And the lead areas basically are where we might undertake national analysis instead of just sticking to our regional analysis. And for our lead areas, we would be the policy link to the National Department of Health. So our lead areas are health inequalities, ethnicity, and tobacco. And for those three areas, we would link with the national organisations on behalf of all the other PHOs. So if the Department of Health has a question, they would ask us and we would answer it on behalf of everybody. And the lead areas that the PHOs have were chosen either because they're a national priority or because they're a significant health problem. And they were allocated to individual PHOs either on the basis of specific skills and interests or because that area was a specific, or that topic was a specific issue for that region. So this is just an outline of our lead areas. So as I said, we've got ethnic minorities, health inequalities and tobacco. But some of the other areas, like the northwest of England, for example, has drug misuse and alcohol among their lead areas, and that's largely because that's the area of England that's got particular problems in those areas. And the London Health Observatory really is best known for its work on health inequalities. So although all the PHOs do work together and we share similar functions as I've described, we're also quite different in lots of other ways. So as we are very small organisations, most of us are hosted by another organisation who looks after our finance, our HR, payroll, those sorts of functions. And the PHOs are hosted by lots of different organisations. So primary care trusts, which is the small health areas in England, host many of the PHOs, and they host the London Health Observatory. But some PHOs are hosted by hospital trusts or universities. And although Most of our funding comes from the Department of Health. That's where our core money comes from every year. We also get additional funding for other things. So we might bid for work, or people will commission us to do extra things on top of our core activities. So the size of each public health observatory does vary quite significantly according to how much additional funding they've managed to gather. And we all work with slightly different regional stakeholders. So, for example, in London, we have the Greater London Authority and the Mayor, which there isn't a kind of similar organisation in any of the other regions of England, and they're one of our primary stakeholders. But we also work with every public health department in our region, with the commissioning teams in our region, and with the local government. And some public health observatories have subunits within their observatory to do specific things. So in England, there's a cancer registry in every region who collect information on cancer registrations, basically. And in some regions, that's included within the Public Health Observatory, and in some it isn't. And we also have, just being set up in England, are quality observatories, which are kind of designed to look after the quality of healthcare. And in some regions, they're also combined with their public health observatory. So each public health observatory does look slightly different. And we all have, although that we all have basic skills that are the same. So our primary function is public health analysis. So there's a big core team of public health analysts. We also all have websites. But we all invest slightly differently in our website. So some will have quite a big web team, and some will have a smaller web team. Some will invest quite a lot in communications activities and marketing, and some don't. So we all look slightly differently in that respect. And because each region has different health issues and different health priorities, the focus of our work does vary a little bit between regions. So I'm going to go on now to talk more specifically about the London Health Observatory and also about our work. And this is just a kind of background slide to describe some of the issues that we're dealing with in London. So we have quite a large population of 7.5 million, and we're very ethnically diverse. 42% of our population is from an ethnic minority group. We've got more than 90 different ethnic groups, and more than 300 languages are spoken. We've got many refugees and asylum seekers. It's a very mobile population. People move around quite a lot. We also have 1 million daily commuters coming into London to work, and about 15 million overseas visitors every year. So all of these bring with them different health challenges. So that's just to set the background. And this, I don't know if you can see that very well, but this is London's geography. So we're a region, and we're a regional health observatory, and we serve the primary care trusts and the local government in London. So there are 31 primary care trusts, and the role of the primary care trust is really to commission services and provide to commission acute services from the hospitals, and to provide community services and to manage primary health care. So that's their main role, and there are 31 of them in London at the moment, although they're due to be abolished very soon. The new government has decided to abolish them. And we've got 32 London boroughs, which are largely coterminous with the primary care trusts, and they're the organisations, the local government organisations within London. And then we've got 33 main acute hospitals, which are located on that map. And this is just the governance structure of the London Health Observatory. So we are accountable to the Regional Director of Public Health for London, who is accountable to the Chief Medical Officer for England. PHOs are governed via a national steering group, which the Chief Medical Officer sits on and the Regional Directors of Public Health sit on. So that's our kind of formal accountability, but alongside that there is the AFO executive who we have to cooperate with and who steer some of the joint work that we might do. And then we also have our own independent advisory board with representatives from all the primary care trusts, from the GLA, from local government, and from organisations like the cancer registries, who help to steer our work programme. So it's quite a complicated structure of accountability. So as I said, our lead areas are health inequalities, tobacco and ethnicity. And this is just a summary of our work this year in our lead areas. So the first thing we did this year on our lead area is update the Health Inequalities Intervention Toolkit, which I'm going to talk about in a little while. We've also done further updates to the local basket of inequalities indicators, which is a basket of indicators that can be used to monitor inequalities in England. And that was designed about 10 years ago, or maybe 7 years ago, and that's been ongoing ever since. We've been updating those indicators. We've done the London Regional Health Profile, which I'm going to mention in a minute. And we've also been working with the Marmot Review. In England, the former government commissioned a strategic review of health inequalities a couple of years ago, and it reported last year in February. And they were basically doing a review of the situation on health inequalities in England. So we were working with them to suggest some indicators that they might use in their indicator framework. So that's the link to that piece of work. And then we've also been working with the Marmot Review team to do a London analysis of the national indicators that they recommended in their review, which I'll just mention in a minute as well. And then on tobacco, we've done the local tobacco control profiles. And on ethnicity, we've done a paper summarising possibilities for an ethnicity indicator in our recent health profiles. This is an example of something from the London Health Profile, and it shows how London compares to the England average on some health determinant indicators. So this is a piece of work that we did with all public health observatories. And basically what it does is highlight where London is doing better or worse than the rest of England on a number of determinant indicators. So on here, we've just got deprivation. We've got children in poverty, which is measured by families claiming benefits. We've got homelessness, exam achievement, and violent crime. So London does... Sorry, what is exam achievement? School achievement at age 16. So it's the percentage achieving 5 GCSE exams at age 16. So we do well on that, but we do badly on all the other determinants of health according to this slide. But we don't do as badly as the north of England. There is a north-south divide in England, and the southern regions of England do much better than the northern regions. So, as I said, the previous government commissioned a strategic review of health inequalities in England, and this is their conceptual framework that they came up with. I'm not going to talk about this in detail, but you can see that there are 6 policy objectives on this slide. So to give every child the best start in life, to enable all children, young people and adults to maximise their capabilities, to create fair employment and good work, to ensure a healthy standard of living, to create and develop healthy and sustainable places and communities, and to strengthen the role and impact of ill health prevention. So those were the policy objectives of the Marmot Review, and they also recommended 6 national indicators, but they didn't define them in any way. Well, life expectancy is pretty well defined, but they left them quite open. So these are the national targets that they proposed, and they relate in some way to the 6 policy objectives, although not exactly. And we've asked them why they don't exactly relate to the 6 policy objectives, and they haven't really said why. But so the first one is life expectancy. The second one is health expectancy, which is a measure of healthy life, really. So life expectancy is a measure of how long you live, and then health expectancy, a measure of how many of those years are healthy. Readiness for school was another one they proposed. They wanted to look at young people not in education, employment, or training, that should say, sorry, household income. And they also proposed an indicator of well-being. The Marmot Review and the English government actually are very, very keen on measuring the well-being of their population instead of ill health. But nobody's managed to come up with a very good indicator of well-being yet. It's still ongoing. Although we tried in this work, we didn't really come up with anything that was very useful. So what we did is we took each of these 6 target areas and tried to define them more closely with an actual indicator. So, and then we produced a profile for each local government organisation in London. So we chose life expectancy, we chose disability-free life expectancy, we chose a good level of development in children, which is basically the percentage of children whose teachers assess that they've got a good level of development in the year that they turn 5. We collect information on young people who are not in education, employment or training, so that was fairly straightforward. And in terms of income deprivation, we looked at the percentage of people in income-deprived households, which is basically those in receipt of benefits. And we produced one of these little charts for each borough in London. We've also done a report on it as well, but we did one of these charts. And this kind of presentation is something that the Public Health Observatories are quite keen on, this little chart, because it basically shows you at a glance. So this borough, Westminster, can see at a glance which areas it's not doing so well on. So the red areas, the red dots relate to indicators where the borough's doing significantly worse than the England average, and the green dots relate to the areas, the indicators where the areas doing better than the England average, and the blue dots are the regional average, I think. And then the grey bar is the range of all values in England, and the dark grey bar is the interquartile range. So for this borough, Westminster, they're not doing very well on child development and income deprivation, but they're doing okay on the others. And this kind of presentation we use quite a lot in lots of different things. It seems to go down quite well. So we're still working on this report, though, and it's going to come out in a couple of weeks. So I'm going to move on now to talk about the Health Inequalities Intervention Tool. We developed the tool because England had 2 targets for reducing national health inequalities. So these were announced in February 2001 by the former Labour government. And they announced 2 targets. One was to reduce the gap in infant mortality between routine and manual groups and the population as a whole. So when they talk about the gap, they're talking about the difference, basically, and between the population as a whole and the routine and manual groups, which is babies whose fathers are employed in a routine or a manual group. So that would be an occupation like builders, labourers, some routine jobs like working on a cash register in a shop, those sorts of things. So the target was to reduce the gap in infant mortality between the population as a whole and babies whose fathers were in those kinds of occupations. So that was one target that they set up. And the other one was to reduce the gap by 10% in life expectancy between local authorities that have, which they term spearhead local authorities, and the population as a whole. And the spearhead local authorities are those authorities that have the worst health and are also experiencing a large level of deprivation. And the worst health was defined by quite a number of indicators. Life expectancy was one of them. Cancer mortality was another one. Cardiovascular disease mortality was another one. So they took those indicators, put them together and worked out the fifth of local authorities. At the time, there were 352 local authorities in England. So they worked out the fifth with the worst health and worked out their life expectancy, and then looked at the population as a whole and aimed to reduce the gap by 10%. And the tool that we built was to help the primary care trusts and the local authorities see how they're doing on these two targets, and to kind of demonstrate how they might make more progress towards improving health in their area and therefore reducing the gap. So, as I said, one of the indicators used to define the spearhead local authorities was the index of multiple deprivation. And that's an index developed by a university in England. It was initially developed at lower super output area level, and they are really, really small geographies of a few thousand people. And so they collected information at that very small geography on 7 domains, which I've listed on the slide. So income, employment, health deprivation, education, skills and training, barriers to housing and services, the environment and crime, and created an index based on all those things for each very small area. And then in order to get a value for the local authority as a whole, they just took a weighted average of the very small areas. And each domain didn't have equal weight, though, in putting the index together. So more weight was given to income deprivation and employment deprivation than some of the other things. Sometimes when we're looking at health outcomes by deprivation, we might just look at the income domain on its own, because you can see there's a health deprivation domain in this indicator. And some people think that if you're just looking at correlating health, if you're looking at the association between health and this index, you're just looking at health against itself. And some people don't mind so much whether you do that or not. So we sometimes just look at the income deprivation domain, but you don't get a great deal of difference anyway. And this link at the bottom provides more information on this index. But it's been around quite a long time in England, and it's been updated every few years when new data become available. So this just maps the index of multiple deprivation in London by the very small areas. So the dark areas on the map are the most deprived areas, and the pale areas are the least deprived areas. So you can see that there's a concentration of deprived areas in inner East London, but there are also some pockets in the rest of London. And the reason I'm showing this map is because these are the spearhead local authorities in London. So these local authorities are the ones that need to reduce their gap with the average. And you can see that they're largely in the same areas as where all the small deprived areas were. So the Health Inequalities Intervention Tool has 4 components to it now. It's developed over time. We first launched one component of the tool at the end of 2006, and since then we've done a lot more work on it, and it now has 4 components. So the first component is the Spearhead tool, which allows authorities that are spearhead areas, not all authorities, to look at their gap in life expectancy, to quantify what that gap is, and to look at the diseases contributing to the gap. The second component is the Spearhead tool, commissioning interventions, and that part of the tool allows authorities to estimate the effect of interventions on life expectancy in their area. I'm going to talk about all of these in more detail. The third component looks at the infant mortality target, and the fourth component is a tool for all areas. So it looks at life expectancy gaps and commissioning interventions, but it looks at it for all areas of England, not just the spearhead areas. And that part of the tool wasn't updated last time round. We did the updating, and it's much more complicated as well than the other parts. So I'm not going to talk about that part today, but I can answer questions on it if anyone has any questions. I'm just going to talk about 1, 2, and 3 today. So the first component of the tool is the Spearhead tool, life expectancy gaps. And this is what that tool does. So it provides information on current life expectancy in the spearhead local authorities. It quantifies the life expectancy gap at birth between the individual spearhead local authorities and the England average. It quantifies the diseases and age groups that are contributing to the life expectancy gap in their area. And it models the effect of 5 high-impact interventions on closing the life expectancy gap. So I'll just go through some examples of those things. So I've chosen on this slide Greenwich Local Authority, which is an authority in London. So this is what the tool tells each local authority about their area. So first of all, it gives them their current life expectancy. So in this case for Greenwich, it's 75.4 years. It tells them what the life expectancy is in all of the spearhead local authorities, which is 75.8 years. So Greenwich is lower than the average for all the spearhead areas. And it tells them what the life expectancy is in England as a whole, which is 77.9. It then tells them what their gap is with England. So in Greenwich has a 3.2% gap with England. And that's what they need to reduce, that gap, in order to achieve the target. And it also tells them whether they're on track or off track to meet the target. So Greenwich, in this case, is off track for males and on track for females. And it does this by extrapolating the current trends to tell them whether they're on or off track. So the other thing it does is breaks down the causes of death that are contributing to the gap. So this is Redcar in Cleveland. It's another local authority in England. And basically what these charts do is break down the gap in life expectancy by cause of death. And we worked this out by substituting. Behind the tool is a life table for each local authority that works out their life expectancy. And to work out the contribution of each cause of death to the gap, we took out, so for each local authority, we took out the deaths for each of these particular causes and substituted them with the England average deaths to work out what each cause of death was contributing to the gap. So you can see for Redcar in Cleveland, cancers. This is males, so cancers contributes to 40% of the gap. And this chart compares that with the spearhead group as a whole for males. So for the spearhead group as a whole, cancers is only contributing 22% of the gap. And you do get quite significant differences in different areas in these charts. So external causes of death, which is suicide and accidents, some areas have quite a big proportion due to those. In here, it's only 15%, but in some other areas, it's a bit more substantial than that. So this helps the local areas to look at the causes that it might want to focus on in terms of reducing their gap. And the tool also does the same thing for age group. So it works out which age groups, in the same way that it works out which diseases are contributing to the gap, it works out which age groups are contributing to the gap. And, also enables the local area to focus their interventions or their work on specific age groups. So you can see this is Birmingham Local Authority. So it compares Birmingham on the left-hand side with the spearhead group on the right-hand side. And you can see there are some differences. So in the under 1 population, Birmingham is contributing much more than average to the gap. So Birmingham might want to think about infant mortality by looking at these charts. And we've found the feedback we've had on the tool, people find these charts really, really useful in helping them think about how they might want to reduce inequalities in their area. So the other thing that the Spearhead tool does is looks at these specific interventions and allows the user to modify these interventions and work out what would happen to their to their life expectancy gap if they modified these interventions. So we've got, at the moment in the tool, we've got 5 interventions. We've got the number of smokers quitting through NHS stop smoking services. It doesn't include the number of smokers quitting on their own without services, but it looks at the number of smokers quitting through using services. It looks at the number of people treated for high blood pressure. It also, although infant deaths is not really an intervention in this context, it looks at what would happen if you changed infant deaths. What would the effect be on life expectancy? It looks at the numbers treated for uncontrolled or undiagnosed hypertension, in those without existing coronary heart disease or stroke, though. And there's an additional intervention for treatment for high blood cholesterol among those already being treated for hypertension. So what the tool does is when you go into the tool, it shows the level of all these interventions in your local area. So it tells you how many people you're already, on average, are quitting through NHS stop smoking services every year, how many people on average are being treated for high blood pressure, blood sugar, the number of infant deaths, etc. And then it allows the user to modify that to see, oh, if I increase that one, what would happen to life expectancy in my area? So these interventions were chosen for a number of reasons, largely because they can be influenced by the primary care trust or the local authority. We didn't want to include things that couldn't be influenced by local areas. And we have information on these things, so we could, it was possible to include them. We also, when we worked with the Department of Health when we were putting this tool together, the Department of Health asked us to work with them to put this tool together because they'd already done a lot of work on which interventions would reduce health inequalities in their area. So they already, in England, nationally, they'd already looked at what sorts of interventions were likely to reduce health inequalities. And what they wanted us to do was take that information and model it locally. so that each local area could use the tool and work out, you know, what would happen to life expectancy in their area. And they wanted us to include infant mortality so that there would be a link through to the other national inequalities target. So that was basically the reason that these interventions were chosen and not others. Although one of the main criticisms of the tool is that there aren't enough interventions in there. It was interesting, actually, because we thought that because some of the information is estimated, we thought we might get a lot of criticism around the methodologies that we've used because we've estimated lots of things and made lots of assumptions in putting the tool together. But actually, people weren't really concerned about that. They just wanted more. So it was okay. So this is an example of how it might work. So this is Redcar in Cleveland Local Authority as well. So currently, when you go into the tool, it'll tell you the current levels. So currently Redcar in Cleveland has 1,150 smoking quitters every year. And it has 29,000 smokers. And it has 16,000 males with hypertension. And the current life expectancy is 77.2 years. So what you can do is go into the tool and say, what would happen if I increased smoking quitters to 3,000, and what would happen if I treated 5,000 of the men with hypertension? So then you go into the tool and you would enter these things in, and then if the tool will then tell you what would happen if those interventions were achieved. So if we had 3,000 smoking quitters and if we treated 5,000 men with hypertension, male life expectancy in Redcar in Cleveland would increase to 77.4 years, which is actually, doesn't appear to be very much. And it will also tell the user what the narrowing in the life expectancy gap would be if they did that. And in this case, it's 17% narrowing of the gap. So it's actually quite significant. And then it tells you that you've achieved the target. It pops up in green, achieve the target. So that's the sort of thing that it does. It's obviously a very simplistic tool, and well, it's quite complicated, but actually it raises as many questions, I suppose, as it answers. And there are things that we need to consider when interpreting the results from the model. So the first thing is it's a static model. So it assumes that there's no change in life expectancy in England, which is obviously not going to be true, because life expectancy is increasing in England, and it's increasing in nearly every part of England. But the model assumes it remains the same. And it also assumes there's no change in life expectancy in the local area due to anything else, which is also not going to happen. But what it does do is it allows the local areas to think about the kinds of scales of interventions they should be using. So it tells them whether they need to aim for 3,000 smoking quitters or 10,000 smoking quitters and the likely effect that's going to have. It doesn't tell them exactly what's going to happen. It doesn't predict anything. It's just something for them to test out various scenarios. So it estimates what life expectancy would be if those interventions had an effect, assuming that everything else remains the same. And lots of people have asked us about the timing of the impact. I mean, the model is essentially a cross-sectional model, but we know that the impact of some things will be quicker than the impact of other things. So smoking cessation, we think, is approximately 5 years before you'll see any change in mortality due to smoking cessation. And but for some of the other things, it's more immediate. So infant mortality, for example, if that reduces by 10% next year, the impact on life expectancy will obviously be immediate. It also assumes that the model allows you to choose a number of interventions. So you could model all of them at the same time and change them all. And it assumes that the effect of the interventions is additive, when really it probably won't be, because there'll be some overlap, like some of the people with hypertension will be the smokers, etc. But it assumes that they're not. So this is just a reminder of the targets, because I'm going to move on to talk about the infant mortality tool now. So the infant mortality target was to reduce the gap in infant mortality between the routine and manual groups, which is babies with fathers in routine and manual groups, and routine and manual occupations, and the population as a whole. So what the infant mortality tool does is it shows recent trends in infant mortality by socio-economic group. It provides background data on factors that may be associated with deaths in infancy. It quantifies the gap in infant mortality and also the contribution of 6 potentially modifiable factors to the infant mortality gap. And again, it allows users to modify those factors and assess the impact on infant mortality if they were to do that. So this is London region, and this is trends in infant mortality in the London region. And the black lines are all births within marriage and joint registrations, which in this case is the population as a whole. The red line is the infant mortality among the routine and manual groups, which is the group that needs to reduce its gap by 10%. And the blue lines are infant mortality rates among sole registered births, which are births registered by the mother alone. So you can see that it's these births that have the highest infant mortality in London and in England, actually. And there was quite a lot of controversy around this target because they were excluded from the target for some reason. So this tool focuses largely on the gap between the routine and manual, the red line on this chart, and the population as a whole, the black line on this chart. This is the background data included in the tool, which are basically factors known to be associated with infant mortality. So we've got infant mortality rates by ethnic group. We've got information on low birth weight. We've got information on children living in poverty. We've got information on mothers smoking during pregnancy, mothers initiating breastfeeding, and immunisation rates. So that's just background information for people to kind of contextualise what's going on with infant mortality in their area. And these are the modifiable factors and the factors contributing to the infant mortality gap. So we've got teenage conceptions, sudden explained death in infancy, smoking in pregnancy, obesity in women of reproductive age, poverty, and not initiating breastfeeding. So these are all factors these are all risk factors for infant mortality that are essentially higher in the routine and manual group, in the target group. And again, this work was done by the Department of Health. They've done their initial work to look at what factors were higher in the routine and manual group. And they've done some work to look at what was the relative risk of mortality, infant mortality, among these groups. And they've done that at national level. And then they asked us to take that and apply it at local level, which is what we did. So again, these factors were chosen because they can be influenced by the local areas. because the information was available and because of the work that the Department of Health had already done to look at this on a national level. So you can't see that very well, but this is London again, and it's basically a breakdown of the factors contributing to the gap in London. So first of all, what it does is it quantifies the gap in London. And you can see it's actually quite small. So so infant mortality among the routine and manual group is 5.0. And infant mortality among all births within marriage and joint registrations in England, that's the population as a whole in this case, is 4.5. So the gap is actually quite small. And the rest of the chart at the bottom illustrates which of these factors are contributing to the gap in London. So you can see that poverty is one of the biggest contributors to the gap in London, and so is sudden explained death in infancy. Interestingly, teenage pregnancy makes a very small contribution to the gap, and this is because most teenage pregnancies are excluded from this, because most teenage pregnancies will be sole registered births, registered by the mother alone, and they're excluded from this analysis. They're not, because the routine and manual group is determined by father's occupation only. So everybody looks at this and says, oh, why is teenage pregnancy so low? And that's the reason. So you can do the same thing with this tool. So this is Yorkshire, an example of Yorkshire and the Humber region. At the moment, 30% of women are smoking in pregnancy. You can decide what you want to reduce that to. So in this case, 25%. And the tool demonstrates what would be the reduction of the gap in infant mortality if you reduce smoking in pregnancy to 25%. And in this case, the reduction in the gap would be 7.3%, which is not enough to achieve the target. So just very quickly, I've talked about some of this already. This is the feedback that we've received on the tool so far. We haven't done an evaluation of this round of the tool. On a previous version, we had some user consultation events to gain feedback in terms of what they wanted us to develop this time round. So this is a summary of the feedback we've had, although we haven't collected it in any kind of systematic way. Most people say it looks very nice, but it's quite complicated to follow, which it is at the moment, because now there's 4 components to it. It has become more complicated than it was before, and we need to look at ways of simplifying it to guide the user through it in a more user-friendly way. Most people find the information on the breakdown of the gaps is more useful than the modelling of the interventions, and we don't know whether that's because they find the modelling of the interventions too complicated. One of the as I've mentioned already, one of the bits of feedback we've had is that there aren't enough interventions in there. They want to see more. So that may be one of the reasons why it's less useful than the breakdown of the gap itself. And they want more interventions even if the methodology isn't very robust, which is quite interesting. I think largely it's because they need to make a case for investment, and they need information in order to make a case for investment. And, they want anything is better than nothing because they're making decisions anyway. I think as much information as they can get helps them. Lots of people have written to us to say, can we have our data? Can we have all the methodology so we can add our own interventions? We can mess around and do our own thing. And we've had lots of questions about when we're going to update it and when we're going to add more recent data. And after completing any of our projects at the LHO, we do a post-project review, which is a formal review process that we do on every single thing. And it involves people working in the team as well as some users and the commissioners, in this case, the Department of Health. So the Department of Health love the tool. They're really, really happy with it. It does exactly what they want to do, and they use it when they go out to local areas to see how they're doing. So the Department of Health has a number of teams which they call national support teams, which are there to support the areas achieve their national targets. And so they go out to the local areas and say, have you used the tool? How are you using it? How can we help you? And it seems to be doing their job for them, and they're happy with that. It did take longer than we'd originally planned to produce it for a number of reasons, largely because the scope changed quite significantly over time. When we were working on it, the Department of Health kept doing a bit more work on different interventions and wanting to add different ones in and change them around slightly, so that took longer than expected. And there were also, we had many dependencies, so we were reliant on other people for things along the way, which took longer than we wanted. If we did it differently, I think we'd do a lot more formal user testing. We've just recently started producing another tool where we're doing a lot more formal user testing of the tool as we go along, and it really is helping to make it a lot more user-friendly. With this one, we didn't do any formal user testing, and I think it shows that we haven't done that. And we would do more extensive communications to promote the use in the future. When we released this version in March this year, we didn't do any formal communications at all, whereas when we've produced earlier versions, we've done quite a lot, and we've even had the Public Health Minister promoting it in some speeches and things like that, whereas that didn't happen with this one. And we monitor the use of the tool, and we can see that it's not as well used, or the initial use of it wasn't as steep, wasn't as high as we got with some of the others when we'd done proper formal communications around it. So that's it. This is where you can get more information.